Hi, good morning, ladies and gentlemen. I'm Dr. Shameen Tan, Associate Consultant with the Division of Surgical Oncology, Head and Neck Surgery at the National University Cancer Institute, Singapore, also known as NCIS. I'm your host for today. Welcome to the Head and Neck Cancer Awareness Public Forum. This event is held in conjunction with the International World Head and Neck Cancer Day. This year, we are focusing on understanding oral and thyroid cancers, and the aim is to raise public awareness on the possible signs and symptoms, risk factors, diagnosis, and treatment of these cancers. Now, before we begin the program, we would like to just highlight some pointers. Your microphone has been muted by default. Please type your questions inside the Q&A box so our specialists will answer your question live during the Q&A segment. Do note that this webinar will be streamed live on National University Cancer Institute Singapore and 365 Cancer Prevention Society's Facebook pages. You may also visit our Facebook page again to review the webinar after today's segment. And we would also like to take this opportunity to thank our partner, 365 Cancer Prevention Society, as well as our sponsors, MSD Pharma Singapore, Varian, a Siemens Healthineers company, as well as Abbott Laboratories, who have helped make this event possible. Now, today we have an exciting lineup of activities for you, including a quiz at the end of the segment. So that will allow you to win up to 15 prizes. Stay with us and listen carefully to our specialists to find the answers to the questions in their presentations. Now, all you have to do is to scan the QR code after the Q&A segment to submit your answers. And we just flashed the questions for you earlier. The first 5 lucky winners with the correct answers will stand to receive a neck massager, as well as Abbott's Ensure Life samples and a shaker bottle. And the next 10 winners will receive Abbott's Ensure Life samples and a shaker bottle. All the prizes will be mailed to the lucky winners after the event. So follow us on our Facebook and Instagram pages to find out the results. Without further ado, we are pleased to start the event and to invite Associate Professor Thomas Loh to give us a welcome speech. Prof. Thomas Loh is a senior consultant with the Division of Surgical Oncology, Head and Neck Surgery at the National University Cancer Institute, Singapore. Prof. Thomas, please.
Thank you very much. So thank you very much, and good morning to everyone here. Firstly, I'd like to thank the team for organizing this Head and Neck Cancer Awareness Forum. Janet, Eunice, and the entire team that had organized this. Obviously, this takes a lot of details, and they have done a fantastic job working very hard for the last 3, 4, 5 months in garnering all the necessary speakers and the communications with various parties. So thank you very much to the team for this. This cancer awareness public forum is really for you, the patients with head and neck cancers, as well as caregivers. Head and neck cancer is a very common affliction, and we are very happy to have that opportunity to be able to bring this to you every year in July. And this is in conjunction with the Head and Neck Cancer Day, World Head and Neck Cancer Day. I would like to introduce you, and you've heard from her, and that's Dr. Shameen Tan. Dr. Shameen Tan is in charge of Head and Neck Cancer Awareness Initiatives. She's a colleague of mine, and we work together just like all the other surgeons that you see, at least in this public forum that you hear from, we work together in the head and neck tumor group in the NCIS. And that includes, of course, Dr. Larry Lim, Dr. Donovan Yu, Dr. Samantha Yang, and Dr. Lanif Ching. They are all fantastic doctors that we have in a national university health system, and we are very glad that they will be able to provide all the care that is needed for all our patients. Now, as I've already alluded to, MPC, head and neck cancers is a common cancer. In fact, it accounts for approximately 10% of all all cancers, and the most common head and neck cancer is MPC, followed by thyroid cancers and oral cavity cancers. And so we've chosen to focus on thyroid cancers as well as oral cavity cancers in this particular symposium. What are some of the common causes? Smoking continues to be one of the major reasons why we continue to see head and neck cancers. There are other factors, of course, and that includes heavy alcohol consumption, as well as an emerging reason that has been put forth as a cause of head and neck cancers, and that's human papillomavirus infection, or HPV infection, much like the virus that has been blamed or associated with cervix cancer in women. So these are some of the common risk factors that we associated with head and neck cancers. The tumors that are at the head and neck area includes occurring in the oral cavity, in the nasopharynx, the oropharynx, hypopharynx, and larynx. So these are all medical terms, but essentially they are in the mouth area, the throat area, as well as the nasal area. So these are cancers that are associated with smoking, as well as some of the other common risk factors like heavy drinking and even human papillomavirus infection. And you know that smoking or tobacco-related deaths occur in approximately 2,500 smokers and 250 smokers every year, right, in Singapore. So the other common cancer is NPC. NPC, or nasopharyngeal carcinoma, is a common cancer, especially in males, especially in the Chinese ethnicity. And in particular, it is likely to be one of the common cancers, top 3 common cancers in males who are between the age of 30 to 60 years. So this is part of something which NCIS and at NUHS that we are doing, and we are actually embarking on a screening program. And this screening program is a national program. It is in collaboration, not just within NUHS, but with the rest of the country, out in Tan Tock Seng Hospital and in other hospitals nationally, whereby we want to offer screening to the public, and there will be eligibility criteria, such as the age group. And in this screening process, we're going to do a blood test. We're going to look at the saliva also, to try to detect whether patients have the type of EBV or Epstein-Barr virus that's associated with the cancer, and will, if it's necessary, we'll examine the patients and so on. So this is a worthy program that I hope if any of the family members or any of the public, without any known risk factors for NPC, would like to check, then this can be a screening program that the public can take part in. And who to contact, we've got a phone number here, and you all can take this phone number. It is open 24 hours. You can message this number too, and so on. All right, so with that, I'd like to allow the forum to proceed the way that was planned, and I'll hand it back to Charmaine, and I'd like to welcome everyone to this public forum. Thank you.
Okay, thanks very much, Prof. Thomas, and we're excited to get the talk started. Let's welcome our first speaker of the day. Our first speaker is Dr. Lim Wei Xian. He's an associate consultant with the Division of Surgical Oncology, Head and Neck Surgery at the National University Cancer Institute, Singapore. And Dr. Lim will share with you a talk on oral cancers. When are oral cancers a cause for worry? Dr. Lim, please.
Good morning, everyone, and thank you once again for attending this forum today. I'm Dr. Lim from the ENT department in NUH, and today I'll be talking a little bit about cancers of the oral cavity. So these are some of the points that I'll be covering during today's talk. First of all, let's ask, what is the oral cavity? Essentially, the oral cavity is our mouth. And when we talk about cancer of the oral cavity, we often divide it into the various subsites of the oral cavity. So the common areas where oral cancer may arise are the tongue, which is in the front of the mouth, the floor of mouth, which is below the tongue, the buccal mucosa, which is the lining of the cheek internally, as well as the gums. Less common areas include the lips, the hard palate, which is the roof of the mouth, and the retromolar trigone, which is an area between the upper and lower last molar teeth. Now, the oral cavity has many important functions. First of all, we need it to talk, and the tongue and the other oral cavity structures help us to articulate our words clearly. It is also important for us to taste and chew our food, and it helps in swallowing by pushing food from the mouth into the back of the throat. Lastly, it forms part of our upper airway, and it is also part of our breathing passage. Obviously, all these functions are very important, and if any of these functions are affected, then the impact on quality of life can be very significant. Worldwide, oral cavity cancer contributes to approximately 400,000 new cases of cancer per year, and the majority of cases occur in Asia. It also accounts for about 200,000 cancer-related deaths per year worldwide. Locally in Singapore, it is the third most common head and neck cancer after nasopharyngeal and thyroid cancer. And in Singapore, it accounts for about 250 new cases and 100 cancer-related deaths per year. As we briefly mentioned earlier, about 50% of oral cancers arise from the tongue. And the other common areas are the floor of the mouth as well as the gums. And the rest of the areas of the mouth are a bit less common. The main risk factors for oral cancers are smoking and alcohol consumption. And it is well known that the risk of cancer is related to both the duration of consumption as well as the amount that has been consumed. With regards to smoking and alcohol, they each carry about a 5 to 8 times increased risk of cancer. But in patients who both smoke and drink, then the risk of cancer is actually multiplied and can be up to 30 times as compared to the normal population. In certain areas of the world, betel nut chewing is common, and this leads to an increased risk of oral cancer as well. And finally, patients with ill-fitting dentures may have an increase in the risk of cancer, and this can be up to 3 to 4 times. So you may then ask, what are the suspicious symptoms and what should I look out for? So one of the most common symptoms that patients see us for is a mouth ulcer that does not heal. And this mouth ulcer can be anywhere in the mouth, but probably the most common area will be the tongue, the floor of mouth, as well as the gums. So this may be one of the earliest signs of oral cancer. As the cancer grows, patients may then feel that there is a lump in the mouth, and this lump may be painful, may cause bleeding, and it may also cause difficulty with eating and speech. Sometimes with a lump in the mouth, patients with dentures may find that the dentures do not fit so well, and this may be one of the signs that there is a tumor growing underneath the dentures. As the cancer spreads, the lymph nodes in the neck may then enlarge, and patients will then experience a lump in the neck. Finally, tumors that are deep-seated can sometimes cause a persistent, unexplained ear pain. And this is because the sensory nerves of the oral cavity and the ear, they communicate with each other. Next, I'm going to show you a few examples of patients who have been diagnosed with oral cavity cancer. So this picture shows a lady with a very early tongue cancer, and she presented with a non-healing ulcer on the left side of the tongue. This next patient similarly had a tongue cancer, but it's a bit larger and more advanced. As you can see, the tumor and the area of ulceration are much larger as compared to the previous patient. Tongue cancers typically occur on the back of the tongue, on either side, either the left or the right side. This is another example of a patient with a cancer of the buccal mucosa, which is the inner cheek lining. And you can see that there is a lump on the inner cheek with an area of ulcer. The other thing that you may notice is that there are some dark discoloration on the lining, and this is because the patient is actually a heavy smoker. This patient had a large tumor involving the upper gums as well as the palate, and involving the upper teeth as well. So other than the first patient, actually all the other patients shown were all heavy smokers and drinkers, and that is indeed the most common risk factor that we encounter locally. So next, how are patients usually evaluated for oral cancers? Now, when patients come to the clinic, we will usually take a comprehensive medical history, and then we do a thorough examination of the oral cavity and the neck. And then we do a procedure called nasal endoscopy, where we examine the internal structures of the nose, throat, and voice box area that cannot be visualized from the external part of the person. If we notice that there is a suspicious lump in the mouth, then a biopsy may then be needed to confirm the presence of cancer. This can usually be done in our clinic in the same setting under local anesthesia. So what we do is that we inject a bit of numbing medication, and then we take a small sample of the tumor and send it off for testing. This test usually takes about 5 to 7 working days for the final result to come back. If cancer is truly confirmed, we will then perform some scans to determine the stage of the cancer. And this is usually a combination of CT scans and MRI scans. Now, you may then ask, how is oral cavity cancer usually treated? Oral cavity cancer is usually treated using surgery. And what we usually do is that we remove the tumor with what we call a margin of normal tissue. And this is to ensure that all the cancer cells are adequately removed. For smaller tumors, this can be done just by opening the patient's mouth, but larger tumors may require other methods to access. For example, sometimes we need to split the lower jawbone in order to access larger tumors in the oral cavity. After removing the tumor, a defect is then created. So small defects can often just be stitched up, but if it's a very large defect, then sometimes we may need to use tissue from other parts of the body to replace the tissue that was removed during the surgery. And we often get our plastic surgery colleagues to assist us with this. Some common methods are the use of skin from either the forearm or the thigh to reconstruct the defect. During the same operation, we'll do something called neck dissection. This is where we remove lymph nodes in the neck. And the reason for doing this is that even though lymph nodes may not be enlarged, both clinically as well as on the scan, there is a pretty high chance that there's microscopic cancer spread to the lymph nodes. And therefore, we will remove these lymph nodes prophylactically. Depending on the stage and how aggressive the cancer is, patients may sometimes require radiation or chemotherapy post-operatively. Sometimes they may require both. Finally, sometimes there are tumors that are not resectable. They may involve critical vessels or structures in the head and neck, or some patients may not be fit for surgery. In these patients, sometimes we use a combination of chemotherapy and or radiation to treat their cancer. Now, here are some examples of patients who have had treatment for oral cancers. So this patient had a very early oral cancer on the left side of the tongue that had been removed. And because it was a small defect, the surgery was done through the mouth and the wound was stitched up primarily. So other than a small area of tissue loss that you can see on the left side of her tongue, the function is completely intact. She can eat and drink with no problems and can speak clearly as well. The tongue movement is also normal. This next patient had a tongue cancer on the right side of his tongue. And because his tumor was quite large, almost half of the oral tongue had to be removed. So in his case, tissue from his forearm was used to reconstruct the defect. And in this picture, you can see that the right side of the tongue is actually the skin from the forearm. And the left side of the tongue is his normal remaining tongue. So this is his appearance about 2 months after completion of treatment, which included post-operative radiation and chemotherapy. And he's already able to eat soft food with no problems, and he has intelligible speech as well. This last patient also had a right-sided tongue cancer, had a similar operation where the tongue cancer was removed and reconstructed with a forearm tissue. So this is many years post-operation. One thing that you may notice is that there is a small scar in her lower lip as well as the midline of her lower jaw. And this is because her tumor was large and required the jawbone to be split to access the tumor. So she is many years post-operation and her wounds have already healed nicely and her function is intact as well. So in summary, oral cavity cancer is the third most common head and neck cancer in Singapore. And smokers and drinkers are at the highest risk for developing oral cancer. So if you or anyone has a non-healing ulcer, a painful lump in the mouth, or indeed if you experience any persistent unexplained symptom in the ear, nose, throat, or the head and neck, please do consult an ENT specialist to get the situation evaluated. You can contact our ENT clinic in NUH at this email, or you can call the NUH appointment line to make an appointment, and we will be more than happy to see you. Thank you very much for your attention and time.
Dr. Lim, for sharing with us that talk on oral cancers. I see that we already have some questions in the Q&A box, and just hang around to the Q&A segment and our specialists will answer the questions live. So I'd like to introduce our second speaker. Our second speaker is Dr. Donovan Yu. He is a consultant with the Division of Surgical Oncology, Head and Neck Surgery at the National University Cancer Institute, Singapore. And Dr. Yu is going to share with us a little bit more about thyroid cancer, early detection and treatment of thyroid cancer. Now, Dr. Yu, please.
Good morning, everyone. Thank you for joining us today. I'm Dr. Donovan Yu. I'm one of the consultants with the ENT department at NUH, and I subspecialize in head and neck cancers and working as part of the tumor group, the head and neck tumor group as part of NCIS. And today I'll be giving you a little bit of information about thyroid cancers and hopefully that will be able to give you a better understanding of how we manage thyroid cancers in general. So I think to start off with, why don't we just really ask ourselves, what is the thyroid gland and what is the function? Why do we even need it? The thyroid gland is a gland that lies in the center of the neck. It's really right in the middle and closely related to the windpipe. Just behind this, you have the food pipe or the esophagus for which you would swallow. In a very, very close proximity as well, there's a nerve that runs up to the voice box, and that actually helps to innervate the vocal cords. And this is critical for when we talk, when we eat, and even when we breathe. Adjacent to the thyroid are very, very small glands called the parathyroids, of which there are 4, 2 on each side. And these glands are actually critical in terms of how we maintain and control calcium levels in the body. So what does the thyroid gland do? The thyroid gland produces a hormone called thyroxine, and this is actually a very critical hormone that actually controls a lot of the different organs that are essential for day-to-day. For example, it controls heartbeat, controls digestion, as well as aids in cognitive functions. Now, there are many, many different kinds of thyroid lumps, but let's really focus on what kind of thyroid cancers there are. In general, we can differentiate thyroid cancers into 2 types. One is the well-differentiated cancer, and the other ones are the poorly differentiated types. The vast majority of patients will present with well-differentiated thyroid cancers, and papillary thyroid cancers account for probably about 80 to 90% of all thyroid cancers. Less commonly, you have another subtype of well-differentiated thyroid cancers, just follicular thyroid cancers, and very much rarer are medullary thyroid cancers. Poorly differentiated or anaplastic thyroid cancers, thankfully, are a very, very small proportion of patients who present with thyroid cancers. So how common are they? As with the title of the seminar today, these are increasingly common. And in fact, if you can see the graph represented here, over the last 20 years, there's been a steady increase in terms of the diagnosis as well as treatment of thyroid cancers. It's estimated that about 1.2% of all adults will be diagnosed with thyroid cancers in their lifetime. I just want to highlight here that this is actually probably underrepresented, and there are probably a larger number than this overall, because a lot of patients may actually not be diagnosed with thyroid cancers. All in all, this is one of the most common hidden neck cancers that we see in our day-to-day practice. One of the hypotheses is that this is secondary to our improved access to imaging, as well as the higher resolution and the better sophisticated imaging that we have nowadays. So what are the risk factors for thyroid cancers? So unlike the oral cavity or tongue cancers, which is a high risk associated with smoking, alcohol, and tobacco, thyroid cancers generally don't have an environmental risk. We do see it more commonly in women, where there's almost a 3:1 predilection. They tend to present earlier in women as well, hovering about 30 to 50 years of age, while men tend to present a little bit later, about 50 to 70 years of age. Another risk factor that we do see sometimes is a positive family history, as well as other hereditary syndromes of thyroid cancers. One of the things that we do know is that radiation exposure is associated with a higher risk of thyroid cancers. And this is very much seen in patients who had childhood treatment with radiation to the head and neck. So what do you expect to undergo when you come to the clinic for evaluation of a thyroid nodule? So I think the vast majority of patients that we see present to us with a lump in the center of the neck. And in the vast majority of cases, this is usually painless. And in fact, aside from the lump itself, there's really not much symptoms per se. In some severe cases, obviously, when the lumps are really, really very big, we can have compressive symptoms. And in these sense, we have changes to the voice, airway symptoms, such as difficulty breathing, sometimes coughing out of blood. And very, very commonly, when it's large enough, it can actually cause compression onto the food pipe, causing it to be more difficult to swallow the food. Now, in terms of what we do in the clinic, a head and neck examination is critical to identify the lump, to evaluate the size, as well as whether or not the surrounding structures are involved. In terms of what we do in the ENT setting, we generally put a nasal endoscope in to assess the vocal cord function. And that's really the voice box, to see whether or not there's any involvement of the voice box. The other thing that we do try to look for sometimes is to see if there's any invasion of the trachea, which is the windpipe that is just abutting the thyroid gland. So in one of these, in this video, you can clearly see that there is potentially a lesion that's kind of invading into the thyroid, into the trachea, and you can see that there's a lesion right there, and these are potential complications in terms of thyroid presentation. Thankfully, this is not very commonly seen. So how do we manage thyroid cancers? Now, in terms of management, we really talk about trying to work up as well as to get a firm diagnosis of thyroid cancers. And this is usually achieved through three elements: clinical examination, which we talked about, thyroid imaging, as well as cytology. So we'll move on to imaging. And one of the most important imagings that we use for thyroid cancers would be actually the thyroid ultrasound, which gives us a very high definition of the thyroid structure. So you can see here, this is a normal picture of a thyroid gland. You can see the windpipe in the center on the left, as well as the right, as well as the left thyroid lobe. On the left side, sometimes you can actually see the back end of the esophagus, which is the food pipe, that's right there. And on this side, you can see the carotid artery, which is the main blood supply to the brain. So the ultrasound is great because it gives us a very highly detailed visualization of the thyroid. And using this, we can actually evaluate and risk stratify the likelihood of cancers in these patients. And this is usually done very easily at the bedside, in the clinic or in the diagnostic suite. And generally, these investigations are painless and with a very, very high yield of information. Now, in certain cases, when the disease seems to be a little bit more extensive, a CT scan may be in order. And these imaging, what we try to look for is whether or not there's other involvement that are outside of the thyroid, such as in the lymph nodes that you can see here, or whether or not the lump is actually going into the trachea in some cases. The most important diagnostic feature that we would do is a fine needle aspiration cytology, where a small needle is inserted into the lump. And from there, we try to draw out the cells, and that can be actually evaluated under microscope to look for those distinct features of thyroid cancer. That being said, I just wanted to point out that, ideally, we always try to get a good sample. Sometimes that's not usually possible because of the nature of the thyroid lump itself. But using these cells, we can actually stratify different grading systems. And from there, we can actually help to interpret the risk of cancer in these patients. And this is actually a very well-established grading system that's been used worldwide. Now, in terms of fine needle aspiration cytology, sometimes though, some pathologies may not be possible to be confirmed on fine needle aspiration. And sometimes we actually do need to remove the thyroid, or at least part of the thyroid, in order to answer the question whether or not this is or is not a cancer. And that can usually be seen in, commonly follicular thyroid cancers. Now, in terms of surgery, what then do we do? So probably I should backtrack and say that in terms of treatment, surgery is by far the best option in terms of thyroid cancer treatment. Surgery can be either removing the one side of the thyroid lobe or the entire thyroid as a whole. And these are what we would refer to as a hemithyroidectomy or a total thyroidectomy. Overall, the decision for whether you undergo a hemi or total thyroidectomy really depends on the clinical scenario, and this is usually discussed thoroughly by your physician or your surgeon. In addition to that, in most settings, we evaluate the lymph nodes at the bottom of the neck, and at the same setting as surgery, we can try to clear out the lymph nodes as well. In patients with very advanced thyroid cancers, there are sometimes more complex surgeries that may be required, such as removing the upper part of the chest bone to allow access to the thyroid, as well as the mediastinal or the upper chest lymph nodes. And in some cases where the thyroid has clearly invaded or gone into the trachea or the windpipe, that area has to be removed as well. Following surgery, some patients may require to undergo adjuvant treatment. That's treatment after surgery. And in most of these cases, patients undergo radioactive iodine, which we will talk about later on, so I won't spend too much time on that. So what do you expect in terms of thyroid surgery? Now, in my first slide, I showed you the anatomy as well as all of the different organs and critical structures around the thyroid. I mean, it's not surprising that people would expect that, after surgery on the neck, it's going to be very critical. There'll be a long time that you're going to be unwell and needs a long time for recovery. That's actually not really the case from our experience. Most of our patients have actually a very short hospital stay. On average, most patients undergoing a hemithyroid or removing of one side of the thyroid go home probably about 1 day after, while patients who undergo total thyroidectomy may have to stay for a little bit longer just to monitor their calciums. But on average, most patients go home about day 3 to day 5 or so. In fact, most of the patients on the first day after surgery, most of them are sitting up, they're walking around, they're able to eat, drink, and actually communicate with you quite easily. So overall, in general, most of the patients that are undergoing surgery actually have a very good outcome in terms of the recovery. It is poignant to know that, like I mentioned previously, the thyroid produces thyroxine, which is a critical hormone. And with the absence of a thyroid gland, unfortunately, most patients will be required to undergo lifelong thyroxine replacement. And that's not always the case, and particularly so in patients who have only removed half of the gland. So while I mentioned that surgery is actually very, very much tolerable, certainly with all surgery, there's always a risk of complications, and it's probably wise to understand why that can happen. We've alluded to that previously with a brief description of the different structures that are around the thyroid gland. Obviously, if there is any injury to the vocal cord, this can lead to changes in terms of the voice, or in some rare cases, breathing difficulties. Generally, the likelihood of that is overall very low. And in most cases, if that does happen, they tend to be transient, meaning to say that they recover after about 3 to 6 months later. In some patients who have undergone both sides of the thyroid that have been removed, they may actually develop a period of low calcium for which they may have to stay in hospital or may require some added supplementation. And finally, in the very rare event that there's a bleeding after surgery, sometimes we may actually have difficulties in terms of breathing during the immediate postoperative phase. So moving on though, let's talk about the different outcomes. Now, one of the biggest factors would really be what kind of a thyroid cancer it is. The vast majority, as I have mentioned, are papillary thyroid cancers, and these are actually very, very, very good outcomes. In fact, in most literature, you would see, most journals describe an excellent outcome. And one of the things that we do see that reflect the prognosis of patients are really the age and whether or not there's any evidence of spread of the cancer, either to the lymph nodes or to the distal, or to the lungs or the bones. So looking at this graph, I just wanted to highlight here. So most of the time when we talk about cancer cure rates or survival rates, we always talk about a 5-year period, and that's really used synonymously for a lot of cancers throughout. In thyroid, though, you can see that the 5-year survival rate right here is probably about the realm of about 98, 99 percentile when patients about 95% of our patients get treatment. And you can actually see that the prognosis is so good that people are talking about following about 30 over years with still a fairly good survival rates. And that kind of reflects on what we know about thyroid cancers today in terms of the biology. Moving on, just want to touch a little bit about the different new methods that people are talking about in terms of thyroid cancer management. We've talked about different ways of actually trying to improve our diagnostics using genetic material. We talk about different methods of management, including just active surveillance, where we don't actually operate on thyroid cancers, but monitor them. And this has been shown to be fairly effective. And studies from Japan have shown that small thyroid cancers can actually be monitored for 10 over years without any change in terms of their size or the general prognosis of patients. We also are moving on into a minimally invasive approach in terms of how we manage thyroid nodules. And finally, we're looking also at different targeted therapies for which I think we have a little bit of a discussion on later as well. So I just want to thank you for your time. And I would be very much happy to answer any questions or any queries that might come about after that. Thank you.
Okay. Much, Dr. Yu. Now, everyone, just remember to keep a lookout for the answers to the quiz questions that are actually in the presentations of the speakers. Also, if you have any questions, you may type your questions into the Q&A box as seen on the Zoom control panel, and our specialists will pick up the questions from there and try to answer your questions live. So I'd like to introduce our third speaker for today. Our third speaker is Dr. Lennis Cheng. He is a consultant with the Department of Diagnostic Imaging at National University Hospital. And Dr. Cheng will be sharing with everyone the topic on radioiodine therapy, what, why, and how in thyroid cancer. Dr. Cheng, please.
Hi, good morning, ladies and gentlemen. My name is Lennis, and I am a consultant with the Department of Diagnostic Imaging in the National University Hospital. I work in the nuclear medicine section within this department. And many people tell me they don't really know what a nuclear medicine physician does. And some have asked me whether it's a new specialty. So I thought it would be nice to start with a little bit of our history. So contrary to popular belief, nuclear medicine is not a new field of practice. Our history can be traced back to 1936, where Dr. Saul Hertz, a physician in Boston, Massachusetts General Hospital, first conceived the idea that the knowledge of how the thyroid gland works can be harnessed in order to devise a new strategy in treating diseases of the thyroid. So iodine, which is a natural element, is a key ingredient that is used by the cells of the thyroid gland to form thyroid hormone. And Dr. Hertz postulated that if he was able to deliver a radioactive isotope of the element iodine to patients who suffer from thyroid disease, he would be able to kill off this diseased thyroid tissue. So through his work with the physicist, Dr. Carl Compton, the isotope iodine-131 was first used on a human patient in the year 1941. So this year is the 81st anniversary of using a radioactive compound to treat disease of the thyroid, and it is the birth of nuclear medicine. In Singapore, thyroid cancer ranks number 13 of all cancers in terms of prevalence, but fortunately it ranks only number 22, the 22nd in terms of cancer mortality. The good news is that our thyroid cancer patients tend to live long, in part due to the less aggressive nature of the disease, and also importantly, in part due to the effective treatment modalities that we have today, both surgical and non-surgical. Broadly speaking, thyroid cancers are divided into two major categories. The first, which is rare, is the anaplastic or poorly differentiated thyroid cancers, and the majority of these are well-differentiated thyroid cancers. The key information here is that a large majority of thyroid cancers, in fact more than 95% of thyroid cancers, fall into the category of diseases that can be treated effectively with radioactive iodine. Now the golden question, of course, will be who will benefit from radioactive iodine therapy and whether you or your loved one should go for radioactive iodine therapy. Broadly speaking, the decision for whether your doctor will recommend radioactive iodine therapy or not is quite straightforward. After the surgeon removes the cancerous thyroid tissue from the patient, the tissue is sent to the laboratory for detailed examination, and the cancerous tissue is categorized into high, low, and intermediate risk categories based on several criteria, among which are things like tumor size, tumor type, and whether the cancers are seen to have spread. The cancer cells are seen to have spread into the blood vessels or the lymph nodes around the chest and the upper neck. This is a busy slide, but I'm just showing two examples of classification systems that are used to guide your doctors about whether or not to recommend radioactive iodine therapy for you. So on the right is the guidelines proposed by the American Thyroid Association, published in 2015. And on the left, something more local. It is the Singapore Thyroid Cancer Consensus Meeting Recommendations, which was published in 2016. So the guiding principle is this: if you have high or intermediate risk thyroid cancer, you are most likely to benefit from radioactive iodine therapy. And generally, for low risk thyroid cancer, your doctor would not be recommending radioactive iodine therapy to you. It is also important for us to remember that the recommendation can only be made after surgical treatment is complete, after the cancerous tumor has been removed from the patient. So it's not very fair to be asking before going for surgery whether or not you need to go for radioactive iodine therapy. Now today, iodine 131 comes in the form of a capsule. The capsule here, shown in the picture on the top right of the screen, is no bigger than any standard capsule-based medication. The capsule is meant to be swallowed whole, not chewed. Now iodine is a naturally occurring element. For those familiar with the periodic table, it is group 7 and is known as a halogen. Naturally occurring iodine, for example, is found in foodstuffs like seafood, shellfish, salt, in the form of iodine 127, which is non-radioactive. Iodine 131, as seen here, is the isotope that we employ for medical uses. It's produced in a pure form within a nuclear reactor. On this illustration, on the left, is a process within a single typical cell of the thyroid gland where iodine is absorbed out of our bloodstream into the thyroid gland, where it will undergo further chemical reactions to form the thyroid hormone as the finished product. So harnessing our knowledge of this natural process in our bodies, we aim to treat thyroid disease or cancers by delivering radioactive iodine in a similar fashion into the cell, which will eventually result in the death of a cell through radiation-induced damage. When you're referred to us, my department, for radioactive iodine therapy, it is for either one of three reasons typically: remnant ablation, adjuvant treatment, and treatment of metastatic disease. We'll go through examples of all of these options, but before I go on, one of the most common questions that I'm asked in consultation is this: how soon after thyroid surgery should I go for radioactive iodine therapy? Or in other words, if I need to delay my treatment, how long can I delay it without causing too much undue harm to myself? Generally, most studies show that if we can expect good outcomes if we go for therapy within 6 months of thyroid surgery for patients who are suitable. After iodine therapy, all of our patients are sent for what we call an iodine whole body scan between day 3 and day 7. This scan does not involve any more injections or taking any more capsules. It is basically an iodine map of the body from the top of your head to the toes. And this scan shows us, the nuclear medicine doctors, where radioactive iodine is accumulating within your body. And this is a typical map of a patient who has gone for radioiodine therapy. So you can see here that there is all the black spots are areas where iodine is accumulating, and here is in the neck of the patient. And so this is typical after surgery. So recapping a slide from earlier, the image you just saw would be typical for a patient who have just gone for radioactive iodine therapy for the purpose of remnant ablation. Remnant ablation is defined as the use of radioactive iodine to destroy tissue that is presumably normal or non-cancerous. Now, why would we want to do that? First, we need to understand that after thyroid removal, a majority of patients will have a small amount of thyroid tissue that is left behind. This tissue can be non-cancerous. How would you benefit from the removal of non-cancerous tissue? Now, the removal of remnant thyroid tissue helps to make the measurement of the cancer marker thyroglobulin extremely accurate and sensitive. Thyroglobulin is produced by non-cancerous cells as well as cancerous thyroid cells, And after radioactive iodine therapy, the test will be extremely accurate for the early detection of possible future disease relapse. Now, in this patient that we saw earlier, you can see that the cancer marker levels of thyroglobulin from January before iodine dropped to nearly undetectable levels within 5 to 6 months after treatment. Now, in this next patient, this is a patient we treated for intermediate risk thyroid cancer, and this is a whole body iodine scan or map that we acquired 4 days after treatment. So again, we see the similar iodine accumulation in the neck area of the patient, which is the remnant thyroid tissue. However, we see something that is unexpected here, which is a spot of iodine accumulation somewhere in the region of the left thigh of the patient. So what we did was send the patient immediately for a CT scan, which proved that there was iodine accumulation within the femur or the thigh bone of the left leg, as you can see here. Now, you should not have iodine accumulation in bones, and what this means is that there is an unexpected site of cancer spread that would not have been discovered prior to thyroid surgery. So the second reason why you might be referred for radioiodine therapy is adjuvant treatment. Now, adjuvant treatment, by definition, is to reduce the risk of cancer coming back. In adjuvant treatment, the main objective is the destruction of small tumor deposits that may still be present after surgery. Now, in these patients, we hope to reduce the risk of recurrence in the future and also to improve the survival of these patients. Now, in this particular patient, a repeat iodine scan, which was done 6 months after the first treatment, showed resolution of the tumor deposit in the left femur. The third reason why a patient might be referred for iodine therapy will be for the treatment of known metastatic disease or disease that has spread to many sites in the body. Now, in this group of advanced stage thyroid cancer, our main aim is to reduce the risk of death by using radioactive iodine to destroy sites of cancer spread that are otherwise not suitable for further surgical removal. Now, studies in this population of advanced cancer patients shows that radioiodine therapy helps to reduce the risk of death in advanced stage disease by a factor of 30 to 40%. Now, radioactive iodine over the years has been shown to be highly effective in suitable patients. Comparing patients who have undergone treatment versus those who have not, research has shown that there is quite a remarkable difference in the proportion of patients who survive beyond 10 years of diagnosis, from as high as 92% in treated patients and as low as 19% in non-treated patients. In one of our most remarkable examples, this is a high-risk patient that we treated, and the first treatment scan shows that the patient suffered from advanced stage disease with cancer spreading to areas such as the lymph nodes in the neck, the lymph nodes in the chest, and here on both sides, many areas in the lungs. Now, if I send the patient for a CT, and you can see that there are indeed sites of hotspots of iodine accumulation in both lungs, which confirm that they are sites of cancer spread or metastasis. In a subsequent radioactive iodine scan, in the same patient, we actually see a remarkable response to treatment. Other than iodine here accumulating within the large intestine, which is normal, the sites of spread or cancer metastasis that we saw in the previous scan have completely disappeared. Knowing that radioactive iodine therapy is effective is probably not quite enough. We also want to know whether it is safe for us. Now, generally, we say that iodine is safe and well tolerated. The lifetime limit for radioactive iodine exposure ranges between different recommendations, but is generally believed to be in a range of the 600 to 1000 millicurie mark. What this means is that even for patients with advanced disease who may require a higher dose of radioactive iodine per treatment, these patients can still undergo 3 to 4 treatment cycles at least before coming anywhere near the lifetime limit for iodine exposure. So when we counsel about the adverse potential side effects of radioiodine treatment, I like to split it into 3 categories. The common side effects, which are thankfully usually minor and temporary, the more serious but very rare side effects, and also the potential side effects that are difficult to quantify. So common side effects can be seen in quite a large number of patients, and they include things like neck swelling, neck pain, or some skin redness. The patients can have saliadenitis, which is inflammation of the salivary glands, which may reduce the amount of saliva production. You may have dry mouth or altered taste. Rare side effects occur in a very small minority of patients, and many patients are concerned about whether there is an excess risk of an unrelated second cancer due to radiation exposure. The answer is yes, potentially, but the number is very small, 20 to 30 patients per 100,000. In some patients, they may be at risk of lung scarring or bone marrow damage. Some things that are difficult to quantify will be things like tumor swelling due to stimulation of TSH, which we will talk about later. And of course, some of our patients are concerned about reproduction dysfunction, things like low sperm count or disrupted menstrual cycles. Another common question is this: whether a patient needs to be or does not need to be admitted to hospital for radioiodine treatment. In the context of Singapore, we are obliged by law to admit all patients who undergo high-dose treatment for isolation, typically for between 48 to 72 hours. The criteria for discharge is quite specific. The radiation exposure measured at 1 meter away from the patient has to be less than 17 microsieverts per hour. The guiding principle of this criteria is that the patient should not expose the public to anything more than the annual allowable public limit, which is 1 millisievert, and the patient should not expose their caregiver to more than 5 millisieverts annually, which is the limit for healthcare workers. Just to put things into context, represented on the bar graph here, the radiation exposure from getting a CT scan of the whole body is about 10 millisieverts. The radiation exposure from flying one way across the Atlantic Ocean is about 0.1 millisievert. And curiously, if you are living in Colorado of the USA, you can be exposed to as much as 6 millisieverts of radiation annually from inhaling radioactive radon. After a patient has consented to radioiodine therapy, there are a few preparation steps to take. These can be broadly divided into preparation you can do yourself at home and preparation that you have to do in consultation with your nuclear medicine doctors. At home, the most important step is to observe a diet that is low in iodine for at least 1 week before treatment. This will help to enhance the absorption of radioactive iodine into thyroid tissue on a day of treatment. There are many foodstuffs that contain iodine, such as seafood, cured foods, and dairy products and eggs. But the most important will be to avoid taking any seafood and to also refrain from taking any multivitamins or traditional medication that are not prescribed by our doctors, because these can contain an unknowingly high amount of stable iodine. In consultation with their nuclear medicine doctors, the patient can also undergo a period of hormonal preparation. Be sure to let your doctor know if you have a CT scan that is planned or some medication that you are taking, because the medication we inject for CT scans and for some conditions like cardiac arrhythmias can contain a high amount of iodine and would have to be avoided prior to radioactive iodine treatment. Now, all patients also undergo a period of thyroid hormone stimulation to maximize the absorption of radioactive iodine during treatment. Now, this can be in a form of hormone withdrawal or injections. Now, both methods are equal in terms of effectiveness, but there are a few pros and cons of each method, which we will touch briefly on. Now, thyroxine withdrawal method involves the cessation of your hormone replacement therapy after thyroid surgery for at least 4 weeks before radioiodine therapy. Thyrogen stimulation involves the intramuscular injection of 2 separate doses of the recombinant TSH, thyroid-stimulating hormone, at 24 and 48 hours before radioactive iodine treatment. Some of the pros of thyroxine withdrawal is that it is free, it is quite important, and it has a slightly more flexible schedule. One of the main pros of the thyrogen injection is that there are no risks of hypothyroid symptoms, which may take place if you have stopped your thyroid hormone replacement therapy, such as low energy, cold intolerance, weight gain, hair loss, or constipation. The main drawback of the thyrogen injection is that it is fairly expensive and your schedule is fixed because the injection must be done 24 and 48 hours after treatment date. However, I need to emphasize that most importantly, to remember that no matter what method the patient chooses, both are considered equally effective preparation methods for radioactive iodine treatment. I would like to bring us through a pictorial journey of what we can expect during radioiodine treatment. So radioactive iodine capsules come in these shielded lead containers with the capsule inside. We use a plastic mouthpiece or straw to transfer the capsule from the container into the patient's mouth. So the capsule is retrieved from the container into the bottom of the mouthpiece, and the capsule is dropped into the patient's mouth by tilting the mouthpiece upwards. Now, these are pictures of the radioiodine treatment facility in NUH. So these are purpose-built radiation safety rooms with dedicated toilet facilities and a decay system that allows us to store radioactive discharge from patients prior to sending it into the public sewage system. This is a picture of the scanner where the whole body iodine map is acquired, usually about 3 to 7 days after radioactive iodine treatment. In the last part of my talk, I would like to share some principles regarding radiation safety precautions. Now, after radioiodine therapy, the patient will inevitably be emitting a small amount of radiation from his or her body for about 5 to 7 days after treatment. Now, in radiation safety precautions, the guiding principle is something we call ALARA, or as low as reasonably achievable. And the best safety practices can be outlined in a few of these steps. Because unabsorbed radioactive, first we advise patients to avoid prolonged close contact for about 5 to 7 days after treatment, and this can include things like not sleeping in the same bed with your loved ones, to avoid close or intimate contact, especially with pregnant women or children, and not to share utensils or towels with patients who have undergone radioactive iodine therapy. Now, because unabsorbed radioactive iodine leaves the human body through the urine, urinary contamination after treatment is actually the biggest radiation safety risk. Where possible, patients may choose to use a dedicated toilet facility at home. And one important advice that I give to men is to sit on the toilet to pass urine, as this minimizes the risk of accidental contamination. However, I would like to reiterate that when it comes to official radiation safety precautions that a patient receives from his or her doctor or the hospital, these precautions are almost always very conservative. In Singapore, when a patient is allowed to return home after iodine therapy, the radiation exposure is already very minimal. I can understand that radiation may be a very sensitive topic to many patients and their loved ones, so I urge you to discuss any concerns you might have in detail with your nuclear medicine doctor, especially for patients who may have logistical challenges at home. For the caregiver, what kind of practice can they adopt to minimize their own exposure to radiation? So as alluded to earlier, hygiene is the most important factor when it comes to handling urine, feces, and other bodily secretions from a patient who has undergone radioiodine therapy. So I would strongly advise the use of disposable protective equipment such as gloves or disposable gowns, especially when caring for patients who might have mobility challenges. Now, urine from patients with catheterization must be disposed of immediately. Just to touch briefly on some short to mid-term considerations for patients who have undergone radioiodine therapy. Now, breastfeeding mothers must stop breastfeeding for this current child because the iodine may be expressed in breast milk and could be harmful to the infant thyroid gland. But the mother is able to breastfeed again for the next pregnancy. For my younger patients, contraception is advised for the first 6 months after radioiodine therapy, and this applies to both male and female patients. Now, for patients who need to travel within the first 3 months after radioiodine therapy, please ask your nuclear medicine doctors for documentation that specifies the date of treatment, the radioactive compound that is used, and the contact details of the treatment facility. Because there are instances where tiny levels of radioactivity can be detected by very sensitive equipment, even up to 90 days after iodine therapy. Lastly, there are special considerations for patients in whom the decision for iodine therapy is not so straightforward. Now, these include, but are not limited to, patients who are on dialysis for end-stage kidney disease, for patients who have limited mobility or are on long-term catheterization, for patients who are on tube feeding or have swallowing problems, for pregnant patients, of course, for breastfeeding patients, and also for patients who are concerned about family planning. So please discuss all these concerns in detail with your nuclear medicine doctors. Now, in summary, I would like to highlight 4 take-home messages. Firstly, radioiodine therapy is a very effective treatment strategy for patients who are suitable. Secondly, it is a treatment that is established, that is safe and well tolerated in a vast majority of patients. And thirdly, patients who have undergone treatment are not considered a radiation risk upon discharge from hospital, but some safety precautions still apply for the benefit of your loved ones and caregivers. And last and most importantly, this short talk cannot cover all the potential questions and issues that may arise, and I urge anyone who might require this treatment to speak to your nuclear medicine doctors for any questions and concerns. Thank you.
Okay, thanks very much, Dr. Leonard. That talk was very informative indeed. Now we've got lots of questions coming in our Q&A box at the bottom of the screen. So we will try to answer some questions live, and you will see that some questions have already been answered with typed replies in the Q&A segment. Okay, and now let me introduce our fourth and final speaker for today. Our last speaker is Dr. Samantha Yang. She's a senior consultant with the National University Cancer Institute, Singapore, and also with the Division of Endocrinology in National University Hospital. She's going to be sharing with us on the topic of personalized treatment in aggressive thyroid cancer. Dr. Yang, please.
Hello, hi. Can you see my slides?
Yep, we can. Thank you.
Okay, thanks. Thank you everyone for attending this thyroid cancer and oral cancer symposium. In my section, I'm going to share about personalized treatment in aggressive thyroid cancer. Okay, this is, okay, I'll forward my slide. Okay, for some reason, my slide is not forwarding. Okay, I'm not sure why, sorry. Okay, so this is the scope of my talk today. I'm going to highlight the outlook of thyroid cancer, discuss briefly about the genetics in thyroid cancer and how to harness this information towards the treatment of thyroid cancer when they get aggressive. I'm going to also list down some of the approved targeted therapies and also the targeted therapies role in the setting of research in clinical trials. Okay, so one slide to summarize the distribution of the thyroid cancers we see and also the outcome of thyroid cancers. So the most common type of thyroid cancer is papillary thyroid cancer, followed by follicular thyroid cancer, Hürther cell thyroid cancer, medullary thyroid cancer, and anaplastic thyroid cancer. Overall, the outcome of thyroid cancer is usually very good. We see that for the first three types of cancer listed in the table, the 10-year survival rate is very excellent. Even in stage 4 disease, 71% of the patients survive through a 10-year period. For medullary thyroid cancer, a study have shown that a 5-year survival rate is in the range of 90s for early stages disease, whereas for late stage 4 disease, the survival is 28%. In the least common anaplastic thyroid cancer, which is the most aggressive form of thyroid cancer, the outcome is poor. And at the end of 1 year study period, only about 20% of the patients survive. So the aim of targeted therapy is also to improve the survival rate of patients with late stage and aggressive thyroid cancer. So how do we know if the thyroid cancer has any genetic changes that can be targeted by specific treatment? In short, we assess the tumor tissue for DNA changes, DNA mutations. If you read, you might come across a few terms that I wish to allude to today. We read about germline mutation, and this kind of mutation is an inherited type of genetic change. This DNA change happens in the sperm or in the egg, and when they fuse to form the embryo, the subsequent person actually has this DNA mutation change in every single cell of the body. This means that for germline inherited mutation, we can do a blood test and test for this mutation even in the blood cells of this patient, and we can tell the patients that you have an inherited form of thyroid cancer. And the other type of mutation would be a somatic mutation, where it is an acquired sporadic genetic change. This is when the mutation happens in a particular organ of the body, and it leads to thyroid cancer, for example, if it happens in thyroid gland. And for this situation, we will need to retrieve the cancer tissue for gene testing. So this slide summarizes some of the common genetic changes in thyroid cancer. It's quite a busy slide, but just to summarize, the diagram shows the main proteins that are involved in thyroid cells metabolism and growth. If any of these proteins become very active, then thyroid tumor can form. These proteins belong to two categories of scientific signaling pathway, the MET pathway and the PI3K-AKT pathway. So over on the left, if there are RAS mutations or BRAF V600E mutations, then the MET signaling pathway would be very active and lead to thyroid cancers, certain specific type of thyroid cancers listed in the boxes. RET mutations can lead to medullary thyroid cancer, and the RET PTC fusion gene can be seen in sporadic cancer and also in cancers that arise because of childhood radiation exposure to the neck. So I'm going to discuss on medullary thyroid cancer for a start. This is because this particular thyroid cancer, the treatment plan actually hinges very closely on the type of gene change. So most of these thyroid cancers, medullary thyroid cancers, have a RET mutation, and 20% are actually inherited. The specific subtype of the inherited RET mutation can affect the chances that a person can develop this kind of cancer. They can affect the age when this cancer starts and the aggressiveness of the cancer, as well as the development of other types of tumors. So certain types of RET mutations actually give rise to aggressive medullary thyroid cancer, developing at a very young age. In some patients, they need to go through early thyroid operation, even at the young age of 1 year old or even 5 years old. The inherited type of this RET mutation is called MAN2, which is the short form for multiple endocrine neoplasia type 2. 2A give rise to a moderate risk of aggressiveness for thyroid cancer, and the patients might have tumors of the calcium parathyroid glands, and this causes a high calcium level. They may also have adrenaline tumor that give rise to high blood pressure. So if we test positive for this kind of RET mutations, then we also test the other corresponding calcium level and the adrenaline levels for these patients. For MAN2B, it has a very high risk of aggressive medullary thyroid cancer, and the patients could also develop adrenaline tumor. This slide summarizes some of the approved targeted therapy in the US by FDA and also in Singapore by the HSA. So targeted therapy essentially attacks specific thyroid cancer cells when they cannot be treated with surgery, radioactive iodine, and they start to spread to other organs very rapidly. The first row over here, so this table summarizes targeted therapy approved for these 3 types of thyroid cancer. Forgot to mention that. So the first row states the 3 types of targeted therapy that are actually known as kinase inhibitors, and they have multiple targets, hence they are known as multi-targeted kinase inhibitor. The agents here, they actually block RET and some of the receptors that are in charge of blood vessel formation in tumors. The second row states that if the thyroid cancer tests positive for this gene change called NTRK gene fusion, then we can give specific NTRK inhibitors such as larotrectinib as well as entrectinib to treat these patients. And these medications are given long-term to control tumor growth. The third row, if tumors have RET mutations, then we can give specific RET inhibitors, and these include agents like selpercatinib and pralsetinib. Lastly, if the tumor has multiple mutations, then some patients might benefit from immunotherapy. And the immunotherapy that is approved officially is the pembrolizumab agent. Okay. Similarly, for medullary thyroid cancer, multi-targeted kinase inhibitors have been approved. The two are listed there, vandatanib and cabozantinib. Similarly, they block the RET protein as well as some of the blood vessels formation receptors. As I've described earlier on, commonly the medullary thyroid cancer actually harbor the RET mutations, and in that kind of scenario, the RET inhibitors can be given for targeted therapy. And similarly, if the tumor has multiple mutations detected, then pembrolizumab immunotherapy can be given. Okay. So why don't we give every single thyroid cancer patient a kinase inhibitor when they have spread to distant organs? We don't do that because these kinase inhibitor therapies, they have not been shown to cure the tumor, and they only prolong progression-free survival, which means that they slow down or stop the growth of tumors. Sometimes they shrink tumors partially, but they are not known to cure the tumors completely. And these agents actually cause side effects very commonly. Things like rashes, fever, lethargy, diarrhea, sometimes high blood pressure, protein leakage of the kidney. So if the patients have metastatic thyroid cancers that are slowly growing and not causing the patients any problem, we prefer to watch carefully over the years and not cause side effects from this long-term treatment. Next, I'm going to talk about anaplastic thyroid cancer because it is an important cancer to treat. It is a very fatal kind of thyroid cancer. It's shown that half of them actually have pre-existing papillary or follicular thyroid cancer. So initially, they have one or two mutations that trigger the cancer formation. And over the years, the tumor actually accumulate more mutations along the way, such as the TP53 mutations. And these new mutations that accumulate along the way causes the cell to grow more aggressively and become anaplastic thyroid cancer. So these are the list of approved targeted therapies in anaplastic thyroid cancer. I brought back this diagram just as a quick refresher so that we can correlate with what we are giving patients for drug therapy. So if the anaplastic thyroid cancer tests positive for BRAF V600E mutation, meaning the tumors have very active BRAF proteins giving rise to the cancer, then we give a BRAF inhibitor to block this protein. The inhibitor's name is dabrafenib. And just to block this pathway even more thoroughly, we give a MEK protein inhibitor to block this whole signaling pathway thoroughly. And this MEK inhibitor that we give is trametinib, and we give it in combination. Similar to the other tumors, if the cancer has NTRK mutations, we can give NTRK inhibitors. RET mutations, we can give RET inhibitors. And if these agents don't work and the tumors happen to have multiple mutations, then they tend to respond to immunotherapy, pembrolizumab. Okay. The targeted therapies of note, they are not given as first option. Usually we would try to do surgery or radiotherapy to treat these patients first. But if these options are not suitable, then we start targeted therapy. This is because targeted therapy, we need to give these drugs, tablets long-term, and they have side effects as well. Pembrolizumab is given as an injection about every 3 weekly in the clinic. If the patients are borderline in terms of suitability for operation, sometimes after radiotherapy or targeted therapy for a short period of time, some tumor shrinkage can occur and then surgery can be considered. So next, I'm going to move on to targeted therapy in the setting of research clinical trials. The primary goal in this setting would be either anti-growth effect or redifferentiation effect. So anti-growth effect means that we give the therapy long-term, and the aim is to stop the growth or to shrink the tumor partially. However, as I've alluded to previously, the patients tend to have long-term side effects. So increasingly, there are more trials that are looking at the second primary goal, which is the redifferentiation effect. So I'm going to describe a little bit more about what this principle entails. So Dr. Leonard has described about the radioactive iodine absorption by thyroid cells. I'll do a quick recap. So this pink cell here is the thyroid cell, and all the thyroid cells have the iodine channel, iodine tubing on the surface for them to absorb iodine nutrients into the cells as a raw material to make thyroid hormones. So radioactive iodine makes use of this principle and tag radioactivity to the iodine so that the medication solution or tablets can be absorbed into the cell, and then the radioactivity then kills off the thyroid cancer cells. However, when the cancers become aggressive, these iodine tubing channels are lost. They stop producing these proteins already, and therefore they cannot absorb the radioactive iodine medications that we give patients. So we also understand that this lack of iodine protein is largely driven by this hyperactive BRAF and RAS protein due to BRAF or RAS mutation. So there are several studies that show that if we block this pathway by blocking these overactive proteins, by giving kinase inhibitors, then potentially the iodine proteins production can improve and increase again. And this would then allow us a window to serve the radioactive iodine medications to use radioactivity to treat the thyroid cancer specifically. And the advantage of this treatment principle is that we don't have to give the kinase inhibitors long term. And the duration of therapy ranges from about 2 weeks to 6 weeks in the studies so far. Just one picture here to illustrate the point. This is a patient with thyroid cancer with spread to the lungs. We see that the cancer no longer absorbs radioactive iodine. However, after 4 weeks of dabrafenib BRAF inhibitor, there is improvement in the iodine channels, and it allowed the radioactive iodine to be absorbed into the lungs. That's why after treatment with radioactive iodine, we see iodine absorption in the lungs on this iodine scan. So locally, we are also conducting this redifferentiation therapy trial. You can read more about this trial in this website using this identifier. I wanted to share about one of the patients in the clinical trial on how he has responded to the therapy. So this patient has papillary thyroid cancer, and it has spread to the lungs. We tried a course of radioactive iodine. However, the lung tumors do not absorb radioactive iodine anymore. We retrieved the thyroid cancer tissue and tested the gene profile, and we saw that the patient had BRAF V600E mutation. So we gave the patients 2 weeks of BRAF inhibitor dabrafenib and 2 weeks of MEK inhibitor tremelimumab. And here we can see that the iodine PET CT scan after 2 weeks of therapy showed improvement in the iodine absorption in the lung tumors as illustrated by these bright spots here. So we went on to treat with radioactive iodine, and we can see that subsequently the iodine managed to enter the lung tumors in this patient. And 6 months down the road, we did a repeat CT scan, and actually some of the lung tumors shrink in size. And this study is still ongoing. Okay, so I've reached the end of my talk. This is a summary of the scope of my discussion today, and we are all happy to take questions now. Thank you.
Thanks very much, Dr. Samantha, for that very informative talk. And we are doing very well on time, actually. So now we've come to the end of the presentations by the panelists, and we'll move on to the question and answer segment. So I think one of the benefit of the webinar style is we've been able to answer some questions, so the replies are typed in the Q&A box as well. But yeah, thank you for your questions, and you can keep the questions coming. So I'll move to the first question, and maybe I'll direct that to Dr. Samantha. And there's this question, the first question that says, do thyroid nodules lead to thyroid cancer? Yeah, Dr. Samantha, please.
Yeah, thank you for the questions. So not all thyroid nodules lead to thyroid cancers, fortunately. In fact, most of the thyroid nodules are not cancerous. And increasingly, you are seeing more and more patients with thyroid nodules because we do health screening or even we do scans for other reasons. And these nodules are coincidentally picked up on those imaging. So therefore, it's important to do ultrasound to guide the nodules that need biopsy so that we can have definite diagnosis as to whether they are cancers or not. So like what Dr. Donovan has said, the series of tests that needs to be done for evaluation of thyroid nodules.
Okay, thank you very much. Now, the next two questions I will direct to Dr. Lim Wei Xian. Dr. Wei Xian, there are two questions on oral cancers and risks of oral cancers. So the first question is, what exactly is betel nut chewing? And there are quite a lot of people in the audience who are nut lovers as well. Does this increase the risk of cancer? And the second is that, someone said surprisingly, alcohol is one of the causes of oral cancers as well. So can we get you to take that question, please?
Thanks. So these are great questions. So betel nut is actually a special type of nut. It's also known as the areca nut, and it's comes from a palm tree. I don't think it's very common in Singapore to consume or chew betel nut, but it's common in, locally India, the Philippines, and some other Southeast Asian countries, where people actually chew the betel nut leaf, and it has a bit of an addictive potential. So your usual nuts like almonds, cashew nuts, peanuts, those are not known to cause cancer. With regards to the question on alcohol, alcohol itself, well, the risk factor is actually excessive consumption of alcohol. So if you talk about definition, that would be about 8 standard drinks for a lady per week. And for men, that would be about 15 standard drinks per week. One standard drink meaning 1 pint of beer, 1 glass of wine, or 1 shot of hard liquor. So the risk obviously increases with the duration as well as the amount that is consumed. It is an antiseptic, but bacteria doesn't usually cause cancer. So it's the alcohol itself that causes transformation in the cells of the lining of the oral cavity that causes cancer.
Okay, thank you very much. The next set of questions that we have, I'll direct to Dr. Donovan Yu. So Dr. Donovan, there are some questions related to side effects from removal of the thyroid gland. So we have a question that says, what is the side effect of removing the thyroid gland? Why the need to monitor calcium levels? And there are some people who also want to know, will the removal of thyroid actually affect metabolism and cause weight gain? Donovan, we can have you to answer the questions.
Sure, thanks. Yeah, so I think there are really 3 questions here. 2 of them are fairly related in the sense that what is the effects of the removal of the thyroid gland? So let's address that first. So the thyroid gland, like we talked about, really controls a lot of metabolism. So effects of removing that is certainly without the thyroid gland, there's going to be a loss of metabolism. And what the second participant mentioned are common side effects of a condition called hypothyroidism, or when there's not enough thyroxine in the body. And in these cases, certainly patients feel low energy levels. They feel, other side effects such as constipation, urinary retention. Sometimes they also have weight gain as well. Now, these are side effects that are actually very easily addressed, and a lot of times, we place patients on thyroid replacements to overcome that. So these side effects should not be seen for patients who are well controlled with the thyroxine hormones. And we'll talk about the second part question, which is really about the calcium levels. Now, these are really temporary effects in most cases. So unfortunately, because the parathyroid glands lie sometimes on the thyroid, they can be removed at certain settings, especially in patients with very large thyroid cancers or when there's a lot of lymph nodes in the neck. Unfortunately, so in a lot of patients though, I think probably about 90% or 95% of them, these are all transient, meaning to say that usually we are able to identify these glands and basically preserve them. But because of the amount of dissection, sometimes the blood supply to these glands are actually stunned for a little bit of time. And so it takes a bit of time for it to reactivate itself. And in these patients,
they usually tend to have a short period of low calcium levels, usually maybe about a month or so. And then after that, it actually comes back. In patients, however, that 5 to 10% who may unfortunately have all the parathyroids taken out because it's stuck onto the tumor, these patients unfortunately may have to have long-term calcium replacements in addition to the thyroid replacement. I hope that answers most of the questions there.
Okay, thank you very much indeed. There are also some questions on things like hair dye. Well, in general, hair dye does not really have a link with head and neck cancers. Okay, Dr. Wei-Sian, there's one more question on oral cancer. And there's a question by Alison that says, what are the chances of recurrence of oral cancers and what's the recovery rate like in general?
So in general, when we talk about the chances of survival, then we look at this term called 5-year survival, which basically means at the end of 5 years after treatment, our patients are still surviving. So this will depend on stage. So very generally, for patients with stage 1 disease, 5-year survival is about 90%. Stage 2 will be around the region of 70%. For stage 3, 50%, and stage 4, about 30 to 40%. That would be the general numbers that we're looking at. Of course, a lot of things also depends on the individual patient's tumor, the type of treatment, and their overall medical condition as well.
Okay, thank you very much. We do have some questions on radioactive iodine, and I'll get Dr. Lenneth to take those questions. So there's a question that says, does radioactive iodine affect the kidney? And is there any evidence to show that using N-acetylcysteine, or commonly known as flumacyl, lessens that effect? And there's another question on how long does the effect of radioiodine actually stay in the body? Yeah. Dr. Lenneth?
Okay, thanks for the questions. These are quite relevant questions. So I'll approach it to answer both questions together. Now, when you talk about radiation, okay, first let's cover the science, which is how long does radioactive iodine stay in the body? Now, radioactive iodine has a half-life of 8 days, which means that it takes about 8 days for the radioactivity to drop to half of the original level. However, this is not the only factor that is taken into consideration. Other than the half-life of iodine, which is known as the physical half-life, we have something called the biological half-life. The biological half-life refers to how quickly our human body can get rid of a particular agent. Now, when you combine these two half-lives together, we have something called the effective half-life. Now, the effective half-life is basically an estimate of the effectiveness of a particular, of how long a injected or ingested compound has on the body, and the effective half-life of iodine 131 is about just below 4 days, which means that every 3 to 4 days, the activity in general of the body drops to half of what it was previously. Now, the effective half-life is contributed by different organs, different systems. So an important concept is the residence time. Now, the residence time refers to how long a particular radioactive substance stays in each particular organ. Now, so for radioiodine or iodine 131, the highest residence time will be in thyroid, which is why we are employing iodine 131 to treat thyroid disease, because it stays in the thyroid for a very, very long time. Now, the residence time of iodine 131 in all other organs are very low, typically very low, and this includes the kidney. So when we talk about radiation toxicity, in principle, it has to do with, like I said, the time of residence, the dose rate, and also, secondly, the radio resistance, or how sensitive the organ is to radiation. Now, our body is able to resist or recover from radiation-induced damage at a certain rate, and you only see the side effects if these recovery systems are overwhelmed by the amount of radiation that is being exposed to. Now, the kidneys are not a very radio-sensitive organ, which means that the kidneys have a innate ability to resist a certain amount of radiation. And because of the combination of these two factors, first, the radio resistance of the kidneys and the time of residence, how can we reduce the time of residence in the kidneys? We can do this by hydration, so that we pass urine at a faster rate and we get rid of the excess radiation more quickly in patients who have undergone radioiodine treatment. So hydration is important. All in all, studies have been done, and the typical findings of these studies is that there is no statistical risk of causing significant kidney impairment in patients who have undergone iodine therapy if they have fairly normal kidney function to begin with. Now, so the next question is, if we already have kidney impairment. Now, in these patients, patients who have significant kidney impairment before iodine therapy, then the nuclear medicine doctors typically would recommend a dose reduction or a less amount of radiation that is being administered, so as to reduce the toxicity. And secondly, because of the reduced kidney function, the iodine is cleared slower, so you actually need less iodine to achieve the same effects in the thyroid. Yeah, so I hope I answered the questions.
Okay, thank you very much, Dr. Lenith. I have a question for Dr. Samantha, and this question came in through the 365 Cancer Prevention Society Facebook page. Thanks very much for the question. And the question says, will one have a higher risk of thyroid cancer if he or she is hypothyroid?
Oh, right. Okay. So actually, when one is hypothyroid, they have high TSH. TSH stands for thyroid stimulating hormone, which is the hormone that comes from the brain that triggers the thyroid cells to grow in every one of us. So when there is a lack of thyroid hormones in the blood, the TSH level is high and it can trigger the thyroid cells to grow. But this high TSH level is not directly well proven to cause thyroid cancer itself.
Okay, thank you. Maybe I'll get Dr. Donovan to answer some of the following questions. So there's a question also from the 365 Cancer Prevention Society Facebook, and it says, what are the initial symptoms for thyroid cancer and how do we prevent ourselves from getting it? Yeah, Donovan?
Yeah, sure. So symptoms in general for thyroid cancers are really just a isolated lump in the center part of the neck. That's probably the most common kind of symptom that we do see. Very uncommonly, some patients may develop other symptoms such as changes in terms of their voice, difficulties in breathing. These are not very common overall. So the vast majority of the patients that we see are basically patients who came in, either they felt a lump or someone saw a lump that's been growing in their neck. In terms of prevention, there's really not very much that you can change in terms of your lifestyle to prevent thyroid cancers. We talked about the risks. In general, thyroid cancers are associated with family histories. And the other thing that can actually have a higher incidence of thyroid cancers are patients who have previously undergone some form of radiation treatment, which is what we had done a long time ago in childhood malignancies. So in terms of lifestyle changes to prevent thyroid cancers, that generally is not very useful, unfortunately. Thanks.
Okay. And sorry, Donovan, I'll just get you to answer one more question. And it says basically for patients who are very young in their 20s who are diagnosed with thyroid cancer, is the quality of life usually affected, and what's the recovery process like?
Yeah, so that's really a difficult question to tackle. I mean, I saw that question as well on the chat. It is really dependent on the stage of the disease and the extent of surgery. But in general, for young patients with thyroid cancers, they do exceedingly well from the survival perspective. In terms of the survivorship, which what we talk about then is the quality of life, it really depends on the extent of surgery. If this was isolated to the thyroid itself, generally most patients have almost an excellent, almost near perfect quality of life. It seems like in the question, there seems to be a lot of morbidity from the surgery, and that really does depend. So it's really a very personal level to kind of establish what kind of a quality of life that person will have. But in general, young patients actually do extremely, extremely well. They go on to have a complete, little morbidity overall in the long term. And they actually are very happy and continue to have the rest of their life with little implications in terms of the thyroid cancer.
Okay, thank you. And one more question. Post-thyroid cancer treatment and total thyroidectomy, is monitoring of thyroglobulin levels, which is a blood test, is that alone enough to detect the recurrence of cancer? And is it also necessary to use other methods like ultrasound to monitor?
So thyroglobulin is a very good cancer marker. And in general, for thyroid cancers, that's actually excellent in terms of establishing the detection of recurrences. It really depends on what phase of post-op treatment or post-treatment the patient is at. In general, though, we do prefer some degree of structural evaluation, and most of us would routinely perform an ultrasound either in the clinic or as part of a diagnostic suite examination. So it depends really on individual practice, but I think both ways are acceptable. Our preference is generally to do both of them in continuum, both the thyroglobulin as well as the ultrasound.
Okay, thank you very much. There's one more question that I'll open up and to the floor maybe. And this question basically says, there's a history, someone has a history of thyroid nodules and was told no intervention except for ultrasound screenings. So in general, for thyroid nodules, now these are nodules that are not known to be cancerous. How frequent should monitoring through ultrasounds be? Yeah, we can have anyone on the floor to answer that question.
Okay, I can try and answer that question. So once we assess the ultrasound features and they show that they are benign looking and don't need biopsy, then we can just monitor these nodules like every 6 to 12 monthly. Some patients with suspicious features on the ultrasound, we do a fine needle aspiration biopsy. And if they are benign, again, we can do the same follow-up around every 6 to 12 monthly in our clinic. After a certain period of time, when we know that the tempo of the nodules is not likely to change, we can widen the frequency of the follow-up to 12 to 18 monthly. It varies on a case-by-case basis.
Okay, thank you very much. Okay. And let me just scroll through. There's a question by Dave, and maybe Dr. Samantha, I'll just get you to answer this question as well. So Dave has a question and he says, does genetic screening help to sieve out early thyroid cancer?
Early thyroid cancer. Okay, I guess early thyroid cancer maybe in the setting of an inherited form of thyroid cancer. Potentially, answer is yes. Inherited form of thyroid cancers, there are 2 types broadly. There's a medullary thyroid cancer and non-medullary thyroid cancer. So for medullary thyroid cancer, the red mutations can be tested. However, we don't routinely screen patients for it unless they have a relative who has medullary thyroid cancer with red mutations. The non-medullary type of familial inherited thyroid cancers basically happens in the setting of syndromes. For example, some patients might have Cowden syndrome, certain gene changes that increase the risk of patients having a cluster of tumors, and some of these patients can be suspected of having these conditions on physical examination. That is when we will do genetic counseling followed by genetic screening for the appropriate gene test.
Okay, thank you.
Yeah, so sorry. So familial thyroid cancer, we suspect it when we have 3 relatives with thyroid cancer.
Okay, thank you. Now, maybe there's one more question that we'll take. Lilian has a question, and that's it. She says, can you check, is there any statistics that show the rate of recurrence, or what's the rate of recurrence of thyroid cancer like in general? Yeah, I'll open this up to the panelists.
Okay, then I can try and answer that as well. So actually, the rate of recurrence in thyroid cancer depends on the histology. After the surgeon cuts out the thyroid gland, what is the features of the thyroid gland tumor itself, whether it's likely to recur or not. If the risk of recurrence based on that is low, then over the next, say, 10 years, the risk of recurrence is less than 5%. If the risk of recurrence is interpreted to be medium, then the risk of recurrence can be about 20% in the next next 10 years. If the risk of recurrence is high because of aggressive features or the tumor has already spread to other organs, then the risk of recurrence is very high, more than 40%.
Okay, thank you. We do have limited time for the Q&A, and I would like to encourage everyone, if the rest of the questions, we will still try to answer them through typing replies. But of course, for the participants out there, if you have questions specific to your own medical conditions, do consider seeing a head and neck or relevant physician to basically evaluate your health condition and also give you better tailored advice to your condition as well. Okay, I want to actually move on to the quiz segment. So thank you very much to our panelists for working so hard to answer the questions live and also typing the replies to the participants. We hope that you have learned more about oral and thyroid cancers. And now we want to get you to participate in our quiz segment and submit your answers. So there are a couple of ways that you can basically submit your answers. So you can either scan the QR code that we are going to flash, and you can use that to submit your answers to the quiz. Alternatively, you can also use the URL that is in the Zoom chat box below to access the quiz submission page. And do remember to key in the correct answers. The first 15 fastest responses that are correct will stand to win a prize from us. So stay tuned on our Facebook and Instagram pages for the results. Winners will be notified via email, and the prize will actually be mailed to your mailing address. So the other thing is also make sure you have provided us with the correct mailing address as well. And we'll give you some time to submit your answers. Sorry, we'll give the participants just about 1 minute or so more to look through the questions and reply this quiz, answer your questions for the quiz segment. Okay, and I think we will put an end to the quiz segment. We have come to the end of our webinar today. Please do fill up the feedback form after you leave the webinar. You will be auto-directed to the feedback form page. And alternatively, you can also scan the QR code on the screen or click the URL in the Zoom chat box below to fill in the feedback form. We'd like to express our thanks. Thank you very much again to the speakers today, Prof. Thomas Loh, who gave the welcome address, as well as our speakers who gave presentations, including Dr. Lim Wei Sen, Dr. Donovan Yu, Dr. Lenneth Cheng, and Dr. Samantha Yang. We also like to thank our partner, 365 Cancer Prevention Society, and our sponsors for today, MSD Pharma Singapore, Varian, as well as Abbott Laboratories, who have helped make this event possible. So a big thank you to all the participants for taking time out to attend our session. And this webinar was quite insightful, at least. We hope you have enjoyed today's session. Have a lovely Saturday and weekend ahead. Thank you very much.